Good day, ladies and gentlemen, and welcome to the APM 201 Series conference call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session, and instructions will follow at that time. If anyone should require assistance during the conference, please press star, then 0 on your touch-tone telephone. I would now like to introduce your host for today's conference, Ms. Sandy Swallow. You may begin.
Well, welcome, everyone. Thank you for joining us for part 1 of the Moving from MIPS to an APM series. The series is sponsored by Compass PTN, Telligen QPP-SURS, and Telligen QIO. And as she said, I'm Sandy Swallow. I'm a project specialist with the QIO and host for today's session. This series is intended for all audiences. We know that there are folks out there that are asking, how do you know if you're ready for to participate in an ACO? And then there are clinicians and practices, they know they're ready, but they're not sure what the next steps are. And then there's the groups of you out there that you're already participating in a Medicare Savings Program ACO, but you're looking for more information about CMS strategic plans for the next few years. And I'm really excited to say that our guest speaker, Dr. Don Clitgard, has you all covered in this presentation. Starting today with the focus topic, going forward in the new alternative payment model. He will lay out the details of the CMS ACO program recent changes with the release of the Pathways to Success. But before I introduce him, there are a few quick housekeeping items I want to go over. The call is being recorded, and this will be posted to our website in a week to 10 days. And as the operator said, your lines have been muted, but she will open the line at the end of the presentation for some Q&A. And as always, we want to hear from you about the thoughts about the event. So your feedback is very important to us. So please take a few minutes to complete the survey when you leave the event. And lastly, I want to take just a couple minutes to introduce the sponsors. Our work as support contractors for CMS is to assist clinicians and their practices in the transition to value-based healthcare delivery systems. Compass PTN works directly with practices in North Dakota, South Dakota, Iowa, Wisconsin, Georgia, Nebraska, Kansas, and Oklahoma, and with the changes needed to transform clinical practices and meet PCPI goals of improving health outcomes while reducing unnecessary hospitalizations and costs. From the Compass PTN today, we have Nikki Carlson and Ellen Cottingham on the call. And then the Telligen QIO supports the small rural practices in South Dakota, North Dakota, Iowa, and Nebraska. And Michelle Brunson is sitting in the room with me, actually. While Telligen QIO, we support all Colorado, Illinois, and Iowa eligible clinicians, especially those in large practices, health systems, and ACOs. So we help support them in meeting the MIPS requirements through customized technical assistance. However, if you're joining us from another state, welcome. We're glad to have you here. Now, again, thank you for joining us, and hopefully you will leave the session with key information that you can take back to your organization. So with that said, it is my extreme privilege to introduce our guest speaker, Iowa native Dr. Donald Clitgard. Dr. Clitgard is the founding CEO of MedLink Advantage, a healthcare consulting and ACO management firm. MLA focuses on the development, support, and management of physician-led MSSP and commercial ACOs, mostly made up of independent physicians, practices, and hospitals. MLA also provides consulting services for healthcare organizations of all types. For 15 years, Dr. Clitgard practiced full-scope rural family medicine and served as medical director of the MIR2 Medical Center Clinics in Harlan, Iowa. During this time, he served as the physician champion for MIR2 in the AAFT's TransferMed National Demonstration Project and helped lead their subsequent patient-centered medical home transformation efforts. He has served widely as an educator and consultant on PCMH transformation in Iowa, regionally and nationally. In 2012, Dr. Clitgard helped found Hartmann Physician Alliance, an Iowa statewide IPA dedicated to helping independent practices thrive. He currently serves as Hartmann Board Chair and ACO Medical Director for both Medicare Shared Savings and Wellmark Blue Cross Blue Shield ACO. A former AAFP president and former member of the AAFP's Board of Directors, Dr. Stuttgart currently serves as the AAFP's Commission on Quality and Practice. He also serves as board chair of the Interstate Postgraduate Medical Association. I am so very pleased to turn this over to him as he shares his wealth of knowledge and expertise with all of us.
Great. Thanks so much for that kind introduction, Sandy. So we'll go through a lot of information today just to kind of set the stage a little bit. We're going to talk about mainly CMS's Pathways to Success program that was put out in the final rule right before Christmas, late 2018. We'll go through that in some depth, kind of cover a lot of the things that has laid out as far as sort of CMS thought process of how things are maybe going to move forward in the Medicare Shared Savings ACO world for the next 5 to 10 years. There will be some slides that have a lot of detailed information on them that I'm not going to read through every line of them, but I do want you to have access to that information and be aware of it. So we'll try and kind of keep my part of the call here, to 40, 45 minutes and leave some time at the end for questions. So that's kind of the layout for today. When you get these slides, just so you know that final rule that was put out on December 21st of last year, if you haven't looked at it yet, there are some hyperlinks in the slides here to the full rule and a shortened fact sheet. There will be some changes. We'll kind of highlight a few of the changes that happened between the proposed rule and the final rule. That's pretty well the way things are going to stand for now, although there will be obviously lots of back and forth lobbying towards continued changes over time, but I think this sets a pretty solid framework for how things are going to move forward in the CMS world going forward. Generally, in big picture, what are some of the opportunities? Kind of start at the 50,000-foot level. There's been a lot of talk in CMS that we all have to move towards risk, and as a family doc, a rural family doc, and working with small independent practices a lot, that holds a lot of concern and a lot of trepidation. One of the things that the new Pathways rule has done is has certainly not backed away from you have to start to take on downside risk, but it has made that ramp up to risk more gradual. There's more stability and predictability in the current or previous ACO contracts that were 3 years. You were having to make decisions on what to do for the next contract cycle before you even really had your second year of full information back to know how you were doing, and that created a lot of sort of instability and concern. So these 5-year agreements will help to mitigate some of that. The Track 1 ACO model with a limited amount of downside risk compared to the next gens and the Track 2s and 3s of past. That Track 1 plus level of downside risk has now sort of been, it was being tried out and is now a kind of ongoing permanent part of the MSSP program. There were some expanded waivers and incentives that we'll talk about that will be implemented once you start to take on a little bit of downside risk. Similarly, you can start to choose how patients are assigned. There's a couple different methodologies that we'll talk about that have been used historically, and it used to be kind of whichever type of ACO you were in, that by default created the assignment methodology. You now have some choice in that. There's some changes to some of the ACO measures and some benchmarking changes that we'll talk about. So that's part of the opportunities. There are some challenges. Previously you could do a 3-year cycle of no downside risk and renew and do a second 3-year cycle of no downside risk. So effectively 6 years of upside only shared savings opportunity. In the new model, that has been significantly shortened, and we'll talk about what that looks like. You do have to eventually move to downside risk, although like we talked about, they've sort of softened that glide path, made it a little more palatable to start at a very low level of risk with some opportunities to get out if things aren't going well. They did also strengthen the termination policies. If you aren't doing well and they want you out of the program, which, if you're not doing well, probably isn't a bad thing, but they have changed their policies on that, which we'll discuss a little bit. There's some new distinctions. There's this concept of high versus low revenue ACOs, as well as renewing versus re-entering ACOs, and we'll talk through kind of the language of what some of that looks like and what that means. And then there's also the whole idea of risk scoring. The RAF risk scoring piece of things, risk adjustment factor scoring that comes out of HCC coding, which some of you may have been familiar with. Risk scores really couldn't rise much at all in the old ACO model. They've significantly capped how much they can rise in this new kind of pathways to success final rule. However, it's better than it was before. They can go up, up to 3% over those 5 years. However, it's a challenge. They didn't put a cap on the downside, how much they can go down. And again, we'll kind of get to the details of that. So we're going to start with sort of what's this new program structure look like. And this is sort of probably the one slide that you may end up coming back to time and again when it comes to understanding or explaining this to other folks. So you can see there's 6 columns on here. So first, focus on the right-hand track, the right-hand most column. So that's called the enhanced track. So basically under the new CMS program structure, you can either be a basic track ACO, which is the first 5 columns, or you can be an enhanced track ACO, which is that 6th column. The enhanced track ACO is more like a current track 3 ACO. So it's a, much higher upside potential. You can see you can get up to 75% shared savings, however, significantly more downside risk exposure. So if you have losses, you're responsible for a significantly higher percentage of those losses. That's that second line down there, or first dollar losses 40 to 75%, up to 15% of your benchmark. So lots of upside, but also lots of downside. And then the last row there kind of tells, depending on where you're at in which of these models, whether you're seen as a MIPS alternative payment model. So even though you're in an ACO, you report under MIPS and get the payment adjustment associated with a MIPS score. Or if you're an advanced alternative payment model and you have enough downside risk that Medicare sees you as an advanced alternative payment model, which means you get a 5% bonus check written to you at the beginning of the year based on your Part B charges, basically 2 years ago, and you don't have to do the reporting under MIPS. So again, that right-hand most column is the enhanced track. So that's folks that are taking on a lot of risk, that are comfortable with that and feel confident in that. I'm guessing that most people on the call today are not going to be sort of in that situation anytime real soon. So we're going to spend the rest of our time sort of talking about the basic track. So you can see the basic track is divided up into 5 levels, levels A, B, C, D, and E. So each of those levels is a year. So kind of think of this as you're signing a 5-year contract in the basic track. Year 1 is level A, year 2 is level B, year 3 is level C, and forward. So you have to progress from one level to the other. So if you start in level A, in the second year you can't stay in level A again. You got to move up to B and C and D and so forth. They have set it such that if you wanted to move from level A in year 1 to level C or D or E in year 2 or year 3, you can move up faster than this kind of A, B, C, D, E methodology. But once you moved up, you can't move back down. So if we kind of walk through it, level A and level B are very similar to the current track 1 ACOs. So you have upside only risk, meaning that if you have shared savings, if through doing good work throughout the course of the year, you save money compared to your benchmark, then you get a portion of that savings back. Under previous track 1 ACOs, that split had been Medicare keeps 50% and 50% comes back to the ACO. Under the new program structure, Medicare is going to keep a little more. If you're not in downside risk, they're going to try and put a bigger carrot on the downside risk part and a little more of a stick on the upside only part. And so you get 40% of those shared savings back, which is an improvement from the proposed rule, which was at 25%. But that's sort of, it's upside only, so you don't have any downside risk, meaning that if you didn't do real well that year and it actually costs more to care for the group of patients in your ACO, than was anticipated and set with CMS's benchmark, they're not going to be asking the ACO to write them a check to cover those losses. They're just forgiven. So that's kind of the upside-only ACO piece, and that is in year 1 and year 2. Then starting in level C, which would be year 3, unless you progress faster than the base, would be your shared savings rate goes up to 50%, but you start to have some downside risk, some shared losses. So if those losses occur, you're responsible for them starting at first dollar losses for 30% of those losses, up to 2% of the total revenue, and there's a cap in there for it's not going to be more than 1% of your benchmark. And you can kind of see level D, similar kind of situation in year 4, 50% shared savings, but the amount of losses you're responsible for just go up a little bit. Still first dollar losses at 30% in all these years 3, 4, and 5, but the maximum you might be responsible for goes up a little bit, from 2% in level C to 4% in level D to 8% in level E. And for reference, that level E portion of risk, so when you get in year 5 of this new program structure, level E, if you cross out level E and wrote track 1 plus, basically level E is identical to the current track 1 plus ACO as far as the amount of upside and downside risk. Okay, so you can see it takes getting to level E though before the CMS is going to say that's enough downside risk that we're going to call you an advanced alternative payment, so you don't have to report under MIPS anymore, and you're going to get that 5% bonus of your Part D charges back as a sort of a lump sum payment. That's kind of the big carrot that they put out there is one of the reasons why folks may want to consider doing that. So that's what the structure looks like. You sign up for a 5-year contract. You'll be in level A through level E. A number of folks would have the opportunity then at the end of that 5-year contract to either choose to move forward into the enhanced track for the next contract cycle, or sign up for a second basic level ACO contract of 5 years, but you wouldn't go back to level A, then you would stay at level E throughout that whole second 5-year contract cycle. So at least as of right now, that's what they're talking about. You go through your first 5-year contract cycle, and then at least a certain subset of ACOs will have the opportunity to sign up for a second 5-year cycle at level E. So that's kind of the big picture. We're getting rid of all the current, basically all of the current methodology and names of the ACOs, track 1, track 1 plus, 2, 3, next gen are all going to be phased out as those contracts end, and ACOs moving forward are going to be in either the basic or enhanced track. So there are some folks that had contracts that ended, ACO contracts that ended on December 31st of this last year. They were able to extend their current contract if they wished through June of 2019. 2019 is going to end up being kind of a weird year because the final rule didn't come out obviously till December of 2018. So they didn't start new ACOs in January of 2019. They allowed ones that were getting to the end of their contract to kind of continue through June. And then now there's this new start date of July 1st, 2019. And they're going to look at July to December, July 1st to December 31st, 2019, as a performance year. So if ACOs, that process is happening right now, which we'll talk about, if you sign up and start on July 1st, 2019, you're going to have this 6-month performance year from July to December, and that 6 months is going to get tacked on to the beginning of the 5-year contract cycle. So you'll actually get an extra 6 months of no downside risk of track A or track D. Wherever you start in the current cycle, that 6-month performance year, even though it's 6 months, they're calling it a performance year, that 6-month performance year will be tacked on, and you'll be at the same level of risk for that 6 months as you will for the calendar year of 2020. So they're kind of doing this to get back to all ACO contracts moving forward will be, a January to December calendar year contract kind of cycle. but because 2019 was different and they didn't want to have this lag because of the timing of these big changes that were happening, they instituted this sort of 6-month extension for January to June, and then a new start date of July 1st for those ACOs that wanted to. If folks don't want to start on July 1st, then they can wait and start on January 1st of 2020 and just go through the normal 5 years starting with that calendar year cycle. So, like we mentioned at the beginning, they're offering slightly different participation options depending on a couple different distinctions. Sort of a new way of looking at things to address a couple different things in the ACOs. And so let's take a look at each of those. So they've now made this distinction between what they call high revenue ACOs and low revenue ACOs. So think about it that a high revenue ACO is not necessarily total amount of revenue like the name might imply, but it's actually how much of the Medicare charges for the group of patients in your ACO are the practices in the ACO, the physicians in the ACO actually responsible for. So how many of those charges are directly billed to the tax ID number entities in the ACO? So if you are, say, in a rural area and patients get most of their care at your critical access hospital practice, and a lot of what gets billed, both outpatient and inpatient and preventive and all of those things, they look at the Part A and Part B revenue of the patients in that ACO, and if more than 35% of those total charges were billed by that entity, right, then you have a lot of direct control over costs. How CMS looks at this. And so they're going to consider you a high revenue ACO, that a large amount of the revenue generated by the charges on these patients is generated directly by the organizations in the ACO. And so in their mind, you've got more direct control over those costs. So they're going to kind of put you in one bucket. Conversely, if less than 35% of those total Part A and Part B expenditures for those beneficiaries in the ACO, if less than 35% of those are attributed to the practices of the physicians in the ACO, then they're going to say you have you may have a fair amount of indirect control, but you have less direct control over costs. So we're going to call you a low revenue ACO. So that's kind of the high versus low revenue ACO distinction. They look at the ACO revenue of the participants based on the most recent calendar year, for which they have all 12 months of data available when they're looking at it. The main distinction between what's it matter, I guess, whether you get classified as a high revenue or low revenue ACO, the main distinction is that if you're a low revenue ACO, then you can do that basic track for 2 agreement periods for a total of 10 years. So like we talked about, the first contract cycle, you would go A, B, C, D, E, 1 year each over a 5-year cycle. But then you could renew for a second basic track ACO contract of 5 years at level E for each of those 5 years. If you're a high revenue ACO, you can do the 5-year basic track cycle, but then you would have to progress to the enhanced track at the end of that first 5 years. So that's sort of the distinction between high and low revenue ACOs, at least under the current rules. So then another distinction they've made is renewing versus re-entering ACOs. So if you have experience as an ACO, so if you're an ACO that's been in existence and you just renew, then you'll be seen as a renewing ACO. That one makes sense, kind of no break in participation. You were in it before, you're renewing again, so you're a renewing ACO. To kind of prevent any gaming, they kind of worry about practices and ACOs sort of shutting down and resuming and gaming the system some by just, calling themselves something different but being the same group of practices, the same ACO as they were before to try and get some advantages. They have this concept now of re-entering ACOs. And re-entering ACOs are either an ACO that's been a legal entity before but took a break and then is now restarting again. So say their contract ended in December of 2018, they didn't renew for this first 6 months of 2019, but when they decided to start up again in July, they've had a break when they haven't been an ACO, they would be considered a reentering ACO. Similarly, if an ACO sort of shut down one legal entity, created another legal entity, and more than 50% of the participants in that new entity have participated together in the same ACO, then CMS is going to say, you've got experience practicing together in an ACO setting because more than half of your practices have been together in an ACO before, and so they're going to categorize those as a reentering ACO. The other last of the third of these kind of distinctions they're making are whether or not you have experience with performance-based risk. So it's not really whether you've just been in an ACO before, but have you been in an ACO where you've had some downside risk before? So have you been in a Track 2 ACO or a Track 3 ACO or any other downside risk-bearing kind of Medicare initiatives? Think of like CPC Plus in some of the states maybe on the call or some of those kinds of things. If you've been in those, if more than 40% of the participants in the specific new ACO have been in one of those prior programs, then the ACO as a whole is going to be seen as having experience with performance-based risk. So again, that's Pioneer, Next Gen, Track 1 Plus, Track 2, Track 3, those kinds of things, right? So why do all those distinctions matter? Well, these next couple tables are going to kind of show you why there is some difference, which is those categories you fall under when it comes to how can you participate in the new Pathways program. So this table you can see at the top is labeled Low Revenue ACO. So these are folks that have been categorized as Low Revenue ACOs. Again, that's kind of the less than 35% of the overall charges were directly attributed to the practices in that ACO, right? So if you're a Low Revenue ACO, then if you look at that left-hand column, if you're a new legal entity, so you're a brand new ACO and you're low revenue, and then in the second column, are you experienced or inexperienced? So if we look at that very first line, you're a new ACO, you're inexperienced, so you don't have any history of knowing how to do downside risk, then you can start in that level A, and you can go level A through E like we talked about, okay? If you're a new ACO, but you're experienced, and you've had, more than 40% of your practices have already done downside risk kind of stuff, they're not going to let you go back and start at the bottom of the totem pole again. You've got to start at level E or the enhanced track. You can kind of see as you look at those lines, if any ACO, no matter how they're categorized otherwise, is experienced with downside risk, then they have to start at least at the level E amount of downside risk. Okay? Probably most of the people on the call would be either if you're starting a new ACO or looking to join an ACO, you would probably, I'm assuming, be looking to find entities that are inexperienced because you can start at a lower level. You can have some years of no downside risk. So most practices that have never done ACO work before, that have never been involved with that very much, want to have 1 or 2 or more as many years as they can get, right, of kind of some no downside risk. Even though the upside potential is a little less, they want to have some time to figure that out before they have to start to take on a little bit of downside risk, right? So if you look at the lines that have inexperienced ACOs, the new ones can start at level A. If you're reentering or renewing, you can't start at level A because they're going to say you've got some experience. We won't make you start in downside risk from the first year, but you only get a start at level B, and you've got to go B, C, D, E, and then your 5th year will be a second year of level E. CMS is not going to allow folks that are reentering or renewing to have quite as many years of no downside risk. So that's how that works. So that's kind of what this table tells you is that first table we showed that says here's the new Pathways program. Where you get a start in that program depends on new or not, reentering or renewing or not, experienced versus inexperienced, and high or low revenue. So that's why those distinctions are important, because they do affect where practices can start. So the next table, same kind of thing, only this is if you're a high revenue ACO. So again, that new legal entity, that new ACO that's inexperienced, can start with level A and do level A through E. Or if they choose, they can. Anybody can start in the enhanced track, by the way. So that's always an option. Most people that haven't had much experience there aren't going to start there, but you can. Similarly, in the high revenue ACOs, you can see if you're experienced in a high revenue ACO and you have experience in downside risk, they're going to make you start in the enhanced track right from the get-go. There's no basic track for those ACOs. Okay. The inexperienced re-entering folks, that line 3, can start in level B. Same with the renewing inexperienced, like former track 1 ACOs can start in level B. So that's where the high revenue ACOs fall out. So there were 2 exceptions you may have seen. If you're a new low revenue ACO, you can start in level A, and you can choose, instead of going level A, B, C, D, E, to go level A, level B, and then have a 3rd year of no downside risk, and do another year of level B. Okay, I think they were responding to feedback that it's not fair that new ACOs can't have 3 years of no downside risk like ACOs have been able to up till now. So they made an exception that if you're a new ACO and you're low revenue and you don't have any experience with downside risk, you can do A, B, B. But if you do that, then in the 4th year, you don't do the C and D thing, you go right to level E. So you can see, you can go A, B, B, E, E, or you can go A, B, C, D, E. So they're kind of giving you 2 different pathways you can choose if you're in that boat. The other one is for high revenue ACOs, that have a one-time renewal option, so with the 1st or 2nd agreement period. So these are folks that maybe had been started in 2016 or 2017, were in track 1 plus model, then they give them some additional options, because that was sort of a new concept, and so they're giving them the ability to elect that level E level of risk. So what's that really mean? Time frame wise, that's a whole lot of information, I know. So let's step back and say, all right, so if you are looking to start an ACO, if you're looking to join an ACO, if you're looking to understand the timelines of when ACOs happen, so you know that for 2019 applications, so if you remember, they didn't start any in January, but there's a July 1st start date now for that last 6 months of 2019. So there was, for new ACOs, they had to put in a notice of intent to CMS that they're going to apply back in January. And actually, if you see that date, the initial application for new ACOs for July 1st of 2019 is today. Okay? So actually, in a couple hours here, I think it's noon Eastern time, actually just past noon Eastern time, today was the time frame where ACOs didn't have to have everything finalized, but they had to put in an application. So there are a group of folks that have been putting together ACOs around the country for a July 1st start date. So if practices that are on the phone or practices you guys are working with have a desire to start in a no downside risk ACO on July 1st of this year and get going with this stuff, right now is kind of a time frame when that is happening. So the applications, the ACO application had to be in by now. There will be a similar kind of application process for 2020 for January 1st, 2020 start. So there will be another group of ACOs that will put in their notice of intent in May and will be signing people up this summer, usually between the end of May and sort of end of July, beginning of August for a January 1st, 2020 start. So the important, I guess, pieces of information probably for the folks on this call would be, if you as a practice or practice that you guys are working with are interested in joining a Medicare Shared Savings ACO, there are actually 2 opportunities this year to get in on the next ACO cycles. Okay, one of those is right now. So Again, ACOs will have turned in their applications by now, but can still add practices to their ACO. I started writing that down. So for a July 1st start date, ACOs can add participants through. I've been back and forth with CMS in the last 24 hours, and they don't have a hard date yet, but it's going to be the beginning of April sometime. So basically, from now we're in mid-February, so, for about the next 6 weeks, if practice have an interest in joining an ACO for July of 2019 and getting that extra 6 months of no downside risk, that's one opportunity that they'll have. Then there will be an additional opportunity in the kind of May to July time frame for starting in January of 2020. So that's kind of how ACOs work. Usually it's just once a year you can sign up, but because of this kind of funky new final rule stuff and how the dates worked out, there's actually 2 opportunities this year, right now and through maybe the first part of April, and then that May to July time frame for a January start. And just so it's clear, if you don't join an ACO at one of those 2 time frames, then you're going to be sitting on the sideline until January 1st of 2020, because the next opportunity then wouldn't come up to join a Medicare Shared Savings ACO until summer of 2020 for that January 1st, 2021 start date. So just so you know, if you haven't been in the ACO world before, that's kind of how timing works with joining ACOs on the Medicare side of things. Most ACOs, it's usually a once-a-year kind of process. And for Medicare anyway, it's usually at summertime you sign up for January of the next year. So those are the dates for right now. So that's kind of the ACO stuff. This next part here, I'm going to fly through at a real high level because I want to leave time for questions. But I want to make you aware of, in addition to kind of the picture of who can apply, when they can apply, how they're going to look, how much risk there's going to be, how those years play out, so all the stuff we've talked about right now. There are a few policy changes about how the ACO program works that were finalized in this rule as well that are important once you kind of get into some of the details. It's probably beyond the scope of this call to get to the nitty-gritty details, but I wanted to at least introduce those ideas to you, so in case you get questions on them or they apply to you and you have questions about them, you'll know that those policy changes are out there. Obviously, those resources at the beginning are all the kind of the nitty-gritty final all the details rules, and then these slides have a fair amount of detail in them to help walk you through that you can refer back to as well. So first of those is assignment changes. I alluded to that at the beginning. It used to be, if you were a Track 1 ACO, how beneficiaries were assigned to your ACO was through this process called preliminary prospective assignment with retrospective reconciliation, which is a mouthful. But what that means is every month you're going to get a new list of these are the people in your ACO. Most of them stay the same, but there's a 10, 15%, depends on your ACO, kind of turnover over the course of the year. People moving away out of your ACO, being assigned somewhere else, people moving in and now getting assigned to your ACO, and so that your list of who are the people you're going to be held accountable for at the end of the year morphs from over the course of the year. So there's pros and there's cons. It's not that one of these ways is good and one is bad, but they are different. So you don't necessarily have a concrete list of here's the people you're going to be accountable for this year, and you may want to really focus your efforts on them. You're going to have some variation in that from month to month over time. That's also what's happening in reality in your practice, so it's probably more real-time recognition of what's really there. The other way was if you were taking downside risk, if you're a next-gen ACO or something like that, then you got prospective assignment, meaning that selection of those beneficiaries, those Medicare patients that you're going to be held accountable for in your ACO, that's going to happen at the beginning of the year, and it's not going to change over the course of the year. That's called prospective assignment. So you can kind of know and focus on these are the people in our ACO, right? And if you're taking downside risk, sometimes that's kind of comforting. As of now, starting in July 1st, each ACO can select which of those 2 assignment methodologies you want CMS to use. Do you want to do the prospective thing with retrospective reconciliation, or do you just want it to know who they are at the beginning? Again, there's thought processes around that, there's strategies around that, but know that you now have a choice. of which of those, and that choice can change from year to year through the 5-year contract. It's not a one and done thing. You can do one year and then change your methodology for the following year. So they also made some revisions to primary care services in their final rule, the physician fee schedule final rule stuff. They had proposed potentially having to make beneficiaries opt in. They did not go forward with that. So if you put about that in the prospective rule, that is something they did not implement in the final rule. They do have a process of voluntary alignment, meaning that if a beneficiary, a Medicare beneficiary, wants to select a practitioner to be their primary provider, and then voluntarily assign themselves to the ACO that practitioner is in, there's a process they can do that. That's been around for the last year, but they've kind of simplified it a little bit. They've also expanded it to all specialties. It used to be just a certain subset of specialty, primary care specialties. They've sort of expanded that definition now. So, and there's also a policy in there that if ACO participant is in a different pilot project, they're not going to assign them to a different ACO. There are waivers and incentives. So these are things that have been around, but they're expanding their use. So the whole idea of a skilled care waiver, that's, right now in fee-for-service, you have to be on acute care for 3 days before you can put somebody on skilled care. This is a way that you can not have to have them on acute care for skilled days. Put them directly on skilled or put them on skilled after a day of acute care if that's more appropriate. Telehealth, there's some telehealth waivers that you can get that take some of the restrictions of geographic site stuff out of there. And then there's a beneficiary incentive program. So if ACOs want to fund a program where if you want to pay your Medicare beneficiaries, $20 to come in for an annual wellness visit, give them a gift card, whatever, you can do that. That's not counted towards expenditures. Medicare's not paying for it. ACO has to, but that was forbidden before. So now, once you move into level C or above, so you're taking on some downside risk, then you can start to use these waivers as part of your ACO kind of strategy or workflow. They made some changes to beneficiary notification. You always have to tell beneficiaries they're in an ACO. They can opt out of data sharing, some of those things. So they've gone back to a little more stringent notification process. But at the same time, they've made it so it doesn't have to just be written anymore. It can still be written, but you can start to use your patient portal or email or other ways to notify patients. There's been some benchmarking changes. How they do the benchmark, this is probably a little more nitty-gritty than most folks on the call want to know, but the benchmark is totally rebased or reset now every 5 years instead of every 3 years, which is good. There'll be a little more stability, and you don't have to worry so much about, is my benchmark going to go up, and I have to keep getting better and better and better every year because there's a major change in my benchmark every year. They've clarified how they do some of the weighting over those years. For how you're feeling right now, so hang in with me for a few more slides. Risk adjustment, again, there's an upside-only cap of 3%, which is not great that there's a cap, but it's much higher than it was before. So basically that means your benchmark can go up as patients are sicker and you're reflecting that in your coding. That benchmark can go up. They did not put a cap on the downside, how far that benchmark can go down if you don't code well. This is just a graphical representation of those loss sharing limits that are in that very first table we looked at. So level B, level C, level D, or level C, D, and E, and the enhanced track, and what those caps are and how they compare to one another. When you move into downside risk, you have to have a repayment mechanism. There is some changes to when you have to change the process around how you're going to do repayment. There's some termination policy issues. Again, the long and short of this, the way I see it is if you're performing real poorly, Medicare can kick you out after a couple of years of performing real poorly. I guess if I'm performing real poorly, I'm probably going to be quitting. I'm not going to wait for Medicare to kick me out, but if they kick me out, that's probably in my best interest. So I guess I don't see anything terrible about this. You can get out termination-wise, just so you know. You can get out each year. They made some, they sort of softened, you can voluntarily terminate within 30 days of notifying CMS. If you do that during a downside risk year, and you terminate, doesn't mean that you then are not responsible for the downside risk portion of the year before you terminated. So you can terminate, but up until the point where you terminated, you would be responsible for that downside risk. So if your brain's hurting, this is the final push. 6 months. So they have these 6-month performance years now. The people that extended from January to June, and the new people that will be starting from July to December, they're going to calculate savings and losses for the whole year and then prorate it for those 6 months. On the quality side, similarly, when you report quality, you'll be reporting it for the whole year, but you'll only be you only be in the ACO for 6 months, but if they say, did you do a colonoscopy, did you do a mammogram, whatever, you're gonna look over the whole year, even though you're maybe only in the ACO from July to December, which makes sense. That's as it should be probably for those things. So things will be reconciled for the whole year, and then you'll get 50% of that in shared savings. If people were in downside risk, they'd be responsible for 50% of the shared losses because it's only a half a calendar year. So that is kind of, I think, the end of most of my prepared remarks. There are 2 educational opportunities coming up that Sandy had said maybe I can make you aware of. One is there's an annual conference coming up, Hartmann IPA. We do an annual conference every year. So just to let people know that this is going to be in Des Moines on March 14th. It is available 6 hours of CME and CEU. Basically, it's this whole idea of how do you prepare for ACOs and alternative payment models and all kinds of issues around that. Right, so how do you use community health workers in a practice? How do you survive in fee-for-service? So how can you use chronic care management or transitional care management codes or whatever to do things well in the short term while you're preparing for value-based purchasing? How do you understand risk better? How do you understand what's going on in the bigger world? So it's available for physicians, administrators, nurses, and even quality staff. Anybody that wants to come, there's a link there if you want to look at it more and register. It's $79 for those 6 hours of CME or CEU. There's also a program for physician leaders. So if you are a physician or if you have physicians that would be interested in career enhancement, how do you lead through all of these changes that are going on in healthcare right now, right? How can you be prepared for all of these value-based purchasing and other changes that are going on in healthcare? There's a physician peer group program called Ascent Physician Leadership. It kicks off in June and December. So there is a link to the website. That's the Hartmann Conference. Again, information and link, and then this is the Ascent information and link that we included at the end there. If you have some interest in that, or you want to forward that to folks that might be interested in that. I'm helping put together the curriculum, and we'll be leading a lot of the physician leadership stuff. So just that's created by IPM, a nonprofit CME group that's been around for 101 years. That's putting together the leadership program stuff. So that is, I think, the end of things, but we still got some time here. Hopefully that we can maybe open things up for questions. I'll maybe turn the slides back over to Sandy in case you need to do anything more.
Thank you, Dr. Cooker. Thank you so much. Lots of very, very good information. I'm going to ask Ashley, our operator, to open up the lines. She'll tell our audience how to open and how to call in.
Thank you. Ladies and gentlemen, if you have a question at this time, please press the star, then the number 1 key on your touch-tone telephone. If your question has been answered or you wish to remove yourself from the queue, please press the pound key. Again, that's star, then 1 to ask a question. To prevent any background noise, we ask that you please place your line on mute once your question has been stated. One moment for questions. And as a reminder, ladies and gentlemen, that's star, then 1 to ask a question. And our first question comes from the line of Lisa Sagwitz. Your line is now open.
Hi. Excellent presentation. My question is, can you confirm an existing ACO can continue their current contract until expiration if they desire?
Yep, correct. And I don't think I did mention that specifically, so thank you for that question. Yeah, so ACOs, we talked about the ones that ended in 2018 could extend. Ones where their contract cycle ends in 2019 or 2020, they can continue their current contract cycle, is what we've heard, I think, pretty solidly all the way through from CMS. If they want to, however, transition to the new Pathways program, my understanding is they will be able to, bow out of their current contract cycle and apply for, the new Pathways program if there is benefit in that to them. But my understanding is that if they're in a current contract cycle, that will be honored to the end of the current contract, and then you would start in Pathways wherever it's appropriate for you based on those definitions we discussed.
Okay, thank you.
You bet.
Thank you. And our next question comes from the line of Christine LaRocca. Your line is now open.
Hello, Dr. Clippard. That was an excellent presentation. I'm actually with Telligen, one of the medical directors. And my question was, as far as experience with downside risk, does participation in the bundled payment for care improvement initiative, either the classic or the advanced, count as experience? I guess you could include CJR, the comprehensive joint replacement, as well, since there's downside risk.
I believe it does. I'd have to go back and look at they listed out in the detailed program, but I believe those were on the list of downside risk bearing programs or whatever, where folks that were in those programs would be, from a Medicare perspective, again, be kind of seen as having experience with downside risk. And then it comes down to individual participants in an ACO might have experience with downside risk. However, when CMS looks at it, they look at all the tax ID numbers, in that ACO, and if less than 40% of those individual tax ID numbers were in BPCI or a Track 2 ACO or, some other downside risk-bearing thing, if that percentage is less than 40%, then the ACO as a whole is still seen as inexperienced. Okay, but if that percentage goes above 40%, then that's where they're seen as experienced. That makes sense?
Yes, thank you.
You bet.
Thank you. And I'm not showing any more questions at this time, but as a reminder, ladies and gentlemen, that's star then one to ask a question.
I see there was one on the chat line. If we don't have anybody else, I guess it says somebody works with a lot of specialists, wondering if there's a place to check and see if ACOs are taking new specialists. So I guess I'm not aware of I'm not aware of a specific resource that that is out there. I think it's ACO specific. So certainly on the CMS website, I know Telligen and Compass have some resources to know who the ACOs are in your market or whatever as well. And CMS's website also, can point you to who the ACOs, at least currently in your area, are. Not necessarily any new ones that are coming to be, but ones that currently are. That is a good question. A number of us are looking at including specialists in our ACOs where we hadn't really taken that step before. So our current ACO that's going to be kind of reorganizing for July, we are now looking for independent specialists that are wanting to join an ACO. And seeing if that doesn't make good sense both for the ACO and for the specialist practices themselves. So I think there's a number of folks that are looking at that right now. There are other ACOs that have kind of gone away from including independent specialists in their group. So I think it kind of depends on the ACO and the dynamics of who's leading the ACO and some of that stuff. But I think you might end up having to reach out to each specific ACO in your market, right, to kind of see if that's something that they're open to or not. I'm not aware of a broader resource than that.
Ashley, do you see any other questions?
And yes, I'm showing two more questions. And our next question comes from the line of London Peterson. Your line is now open.
Hi, thank you for taking my question. I thought earlier in your presentation you alluded to how ACOs can choose how their patients are assigned. Can you go into that a little more specifically?
Sure. So that was preliminary prospective with retrospective reconciliation versus the prospective assignment. So, CMS has had those two different assignment methodologies before. The difference now is that instead of just being stuck with one of those when, based on the type of ACO that you are, when you are in the Pathways program, each ACO every year gets to choose which of those two assignment methodologies that CMS uses, right? So it's not that they've come up with any brand new methodologies, but the difference is now if I'm in a no downside risk ACO, but I would like to have them use that prospective assignment methodology so I know on January 1st who the patient or February, I know who my patients are going to be for the next year, right from the beginning of the year, right? I can choose that as an ACO. So that's the new kind of the new flavor of the Pathways program is being able to choose which of those two methodologies you have. And then there's sort of the additional piece of the voluntary alignment where Medicare beneficiaries can choose the physician, the practitioner that they want to be associated with, and therefore the ACO that practicing physician comes under would be the ACO that they would be attributed to. Does that answer your question?
Yes, thank you.
Oh, sure.
Thank you. And our next question comes from the line of Deanna Grand. Your line is now open.
Thank you. I just wanted to kind of think about this question that came up with the specialist because I was just very curious what might attract like a dermatologist or a highly specialized retina, ophthalmology type practice to join an ACO. What do you think is in it for them?
So that's a very good question. So historically, I would have said not much, maybe, right? That's a hard. How do you wrap your head around what's the benefits both for the ACO and for the specialist? Because a lot of the attribution in the ACO, the vast majority of the attribution gets driven through primary care, right? So from an ACO perspective, having a lot of specialists isn't going to necessarily pull a lot more patients into the ACO. And so therefore now from an ACO perspective, working more closely with specialists, especially that are in high cost kinds of subspecialties, could bring some cost savings to the ACO. And if you kind of figure that out jointly and mutually, you could certainly come up with a process where some of the shared savings would go back to the specialist because they're being more attuned to high cost interventions and doing things appropriately for patients, those kinds of things, right? The biggest thing though, the thing that I think is kind of the kicker that may well get some subspecialists to think pretty strongly about joining the ACO comes down to MIPS. So if that subspecialist has to report under MIPS, and there are quite a few subspecialists that do have to report under the MIPS program, right? And if that's a struggle for them, if that's a struggle for their office to go through the MIPS reporting, process, either just because of their specialty or how their office is set up, the resources they would need, that's not something they've ever done or had to do that kind of stuff before. For a lot of subspecialists, that's really, really a struggle. And the potential is that MIPS program ramps up. You can get a 7% bump or a 7% decrease, and next year a 9% bump or a 9% decrease in fee-for-service Medicare. Those potential dollars that are on the line from those MIPS payment changes can get very substantial for subspecialists, right? And so the benefit for a subspecialist joining an ACO is every provider in the ACO gets the same MIPS score. So, I've got an ACO that our MIPS score last year, was 98.9%, and we got the near maximum positive payment adjustment, right? So the benefit for a dermatologist to join an ACO like ours would be he doesn't have to do separate MIPS reporting. The MIPS reporting that's done by the ACO covers his MIPS reporting requirements for the whole year, doesn't have to do anything separately or additionally, and the same MIPS score that all of the docs that are in these high-performing primary care practices are getting that can bump payment adjustment up by that, whatever that ends up being in these next years, 5, 7, 9%, type of thing when it comes down to it. He or she is protecting themselves from a negative adjustment if they can't report under MIPS and potentially seeing great advantage to a large payment adjustment on the positive side by being affiliated with an ACO that scores very well under MIPS or the MIPS APM. So does that make sense? I mean, to me, that's probably the biggest driving factor out there for independent subspecialists to join a high-quality ACO in their area that's going to score well under MIPS.
Well, thank you. I really appreciate that insight.
You bet.
Well, we are after the hour, and I just want to be respectful of Dr. Clifford's time, and I just can't thank you enough. Wow, we've tapped into a lot of information today. If you did not receive the slides from me, they will be out on our website, or also you can email back to me, and I will send them to you separately. On the slides today, now we see Part 2 and Part 3 of this series and the registration link. Dr. Clifford will be sharing more information with us on overcoming the challenges of transitioning to an APM on April 16th. So we look forward to hearing more from you. Can't thank you enough, Dr. Clifford, for your time and all the knowledge that you have brought forth for us. And thank you all for joining us. We appreciate that. Everybody stay warm and stay safe.
Thank you. Ladies and gentlemen, thank you for participating in today's conference. This does conclude today's program, and you may all disconnect.